All right. Good afternoon and welcome to Internal Medicine Grand Rounds. I have the pleasure of introducing two speakers today, the first of whom is Dr. Siobhan Proksell. Dr. Proksell is a gastroenterologist and assistant professor of clinical medicine here at the University of Miami Miller School of Medicine. She attended University of Miami for medical school before completing her residency in gastroenterology fellowship at the University of Pittsburgh, where she also served as clinical assistant professor of medicine. Dr. Proksell specializes in inflammatory bowel disease and also has an interest in medical education. Please join me in welcoming Dr. Proksell as she presents her talk titled Updates in Gastroenterology.
Thanks, Dr. Forney. So today I am going to talk about the recent updates in colorectal cancer screening, colorectal cancer chemoprevention, C. diff, checkpoint inhibitor colitis, and H. pylori treatment. So we'll start with colorectal cancer screening. We know that it's a common malignancy. It's the fourth most common malignancy in the US. And this year, there's estimated to be about 150,000 new cases alone. It's overarchingly preventable. And if you see this graph at the bottom, the rates of new cases and death rates have decreased since 1975. Now, who gets this? Primarily, most common in Black males, and then in the older age group, over age 55, which we know, but there's a substantial amount of people under age 55 that are getting diagnosed with this malignancy. So this year, the USPSTF changed their recommendations for colon cancer screening and noted that we should start offering screening to patients at age 45. I told you that rates are decreasing, so why is this change? This is primarily declining in the age group over 55, but there's annual increases in rates of colorectal cancer in the younger patient population. So about 1.5 to 2.5% annual rise in the patients that are age 20 to 29 and 0.5 to 1.3% in age 40 to 54. From 2000 to about 2014, there was a 15% increase in colorectal cancer in patients age 40 to 49, and that's fairly substantial, so it's something that we really need to pay attention to. Additionally, a lot of these younger patients are getting diagnosed at a more advanced stage. Some of it has to do with the fact that when younger patients present with these symptoms, it's attributed to hemorrhoids or IBS, but it's important because the stage of diagnosis really determines 5-year survival rates. Localized colorectal cancer has a 5-year survival rate of just over 90%, but colorectal cancer with distant metastases has a 5-year survival rate of just under 15%. So huge differences there. And then we also, want to know, are these potentially tumors that have more aggressive behavior, right? They're showing up in younger people and they're showing up earlier. And then is there a hereditary component? So if you look on the left here, you can see that younger patients have more, obviously, rates of Lynch syndrome in comparison to older patients. So you go 10% and then 3% over here. Polyposis syndromes are also more common. But again, the majority of patients don't have these DNA, germline mutations in DNA mismatch repair genes, and they don't have these polyposis syndromes. They're still de novo colorectal cancers. So how do we screen patients? And again, these are patients of average risk. So stool-based tests or direct visualization tests. The stool-based test or fecal occult blood, it requires 3 samples, and patients also need to have dietary changes beforehand to avoid a false positive. FIT testing is looking at antibodies in the stool to detect blood, and then stool DNA FIT testing is also looking at DNA biomarkers from cancer cells that are shed. Again, if these patients have a positive test, they then need to have a colonoscopy. The direct visualization tests are going to be colonoscopy, CT colonography, and then a flexible sigmoidoscopy with or without a FIT test. All of these require a prep. And I think a lot of patients don't realize that the CT colonography itself requires a clean out. It's important that we get good visualization. The other thing to take into account here is the colonoscopy, and typically the flexible sigmoidoscopy also requires sedation. So patients are having to take time off work. In reality, the best test is going to be the one that your patient gets. So make sure you have a discussion with them in regards to what's actually doable for them so that they can have an effective screening test. Now, can we prevent colorectal cancer? Are there anything that we can do in specific populations? So aspirin has been studied pretty extensively. And it seems that there are decreased rates of colorectal cancer, but after a latency period of 10 years. So there was a pooled analysis of 4 trials that included about 70,000 people. And from 0 to 12 years of taking low dose aspirin, they really didn't see a difference. But then in taking 3 of these studies, which was about 50,000 patients, there was a 40% decrease in colorectal cancer rates from year 10 to 19. using low-dose aspirin. So you need that period of time. Additionally, there was a study in Lancet that looked at 5 randomized controlled trials, and this showed that low-dose aspirin decreased rates of colon cancer. There was a decreased 20-year cumulative risk of 24%. So again, it really seems to be based on the duration and not the actual dose of aspirin. The anti-neoplastic effect that we see is from inhibition of COX-1 and COX-2 activity that decreases prostaglandin E2. So we're suppressing tumor growth in that way. Oops, sorry. So who do we use this in? You need to be discerning about your patient population because there is obviously risk associated with use of aspirin. The patient should be under 70 years old because remember, you need to have this on board for at least 10 years. And they should also have a 10-year cardiovascular risk of greater than 10%. So you can use your ASCVD calculator to estimate that. And they should not be at high risk for bleeding. So you shouldn't have patients that have known peptic ulcer disease that have had histories of GI bleeds or intracranial bleeds. It's also something that you can consider in patients with a history of colorectal cancer. So there have been 2 trials, one in the US and one in Japan, showing that utilization of aspirin has decreased adenoma recurrence rates within a year of cancer for the US study and within 2 years in the Japanese study. So definitely something to consider here. The other question is, are non-aspirin NSAIDs appropriate to use? And based on the data, there does seem to be some protective effect from colorectal cancer. However, there are significant adverse effects that we need to take into account: peptic ulcer disease, intracerebral hemorrhage. So overarchingly, it's not recommended to use non-aspirin NSAIDs. It's primarily aspirin in the appropriate patient population. What about metformin? So there have been meta-analyses of observational studies here. So there were 14 studies that were looked at, almost 500,000 patients here, and overarchingly showed a 27% reduction in colorectal cancer incidence in patients with type 2 diabetes who were taking metformin as compared to those patients who were on no medications or who were taking alternative medications for their diabetes. Interestingly, there was also a randomized controlled trial in Japan of 151 patients who were non-diabetic patients but had a history of adenomas. And after 1 year, there was a 40% decrease in adenoma formation in this population. Again, non-diabetics, but a smaller study. So the mechanism of action here and the anti-neoplastic effect has to do with decreases in insulin and insulin-like growth factor, as well as activation of the AMPK pathway, inhibiting the proliferation of the colorectal cancer cells. Right now, the recommendation is really to utilize metformin in type 2 diabetic patients. There's not really enough information to say it's appropriate in those without diabetes. What about vitamins? So with COVID and with social distancing and isolation, we've seen, I think, a lot of influencers on social media promoting things like vitamins and herbs and essential oils. And right now, we really just don't have the data to support its use for chemo prevention here. So calcium has been evaluated pretty extensively. There was a large follow-up study of the Nurses' Health Study, and it did show that higher intake of calcium was associated with a decreased risk of colorectal cancer, but higher intake of calcium has also been associated with prostate cancer, and we know that there are significant complications that can happen with hypercalcemia, so the benefits here really don't outweigh the risks. With vitamin D, the studies haven't shown clear benefit yet, but there's a large study going in Australia that should have data within a few years, so that might obviously change the recommendation here. And folic acid is also interesting. Low folic acid levels have been linked to higher rates of colorectal cancer and adenomas, but ultimately, when there's been trials that have been done supplementing folic acid, there's really hasn't been any benefit. So ultimately, none of these are recommended as chemo prevention. And then statins. So really, this data is mixed. There was a nice national database from Korea that showed that there were decreased rates of colorectal cancer with use of statins, but then there were other observational studies that had negative results completely. It's overarchingly insufficient evidence. Right now, the rule is really unclear, so it's not recommended. The take home here is that the use of aspirin and metformin in the appropriate populations can be beneficial and something to consider. So let's move on to C. diff, which is something I think we've all encountered in one patient or another. ultimately, can we prevent it? So there's been a lot of data going back and forth about the use of probiotics. The most recent guidelines from the American College of Gastroenterology actually recommend against its use. They're dietary supplements, so they're not regulated. We don't actually know what's in them, regardless of what's documented. And there's harms associated with them. And I think a lot of times people seem to think that because they are a probiotic or they're marketed as a natural supplement, that there's nothing that can harm them that's associated with it. But we know immunocompromised people can get bloodstream infections from them. And actually, recent data has shown that probiotics are actually impeding normal gut recolonization after infections. So it's slowing things down. Now, why did the ACG come out with this recommendation in spite of what maybe some other things have societies have recommended? So there was a multi-center randomized double-blind placebo-controlled trial that was done at multiple hospitals. It included 3,000 elderly patients. And if you look here on the left, you can see that these were the patients that received probiotics and these were the patients that received placebo. There was really no difference in instances of antibiotic-associated diarrhea or C. diff diarrhea in these populations. When they did a subgroup analysis, there maybe was some benefit in patients greater than 77 years of age, but overall in this study, the rates of C. diff were actually quite low. So it wasn't enough to push them to make a recommendation to utilize probiotics. Additionally, there was a Cochrane review that was published in 2017. And this actually concluded that there was a modest benefit to utilization of probiotics. But when you really get down into the details here, there's 31 studies. Many of them were missing data. Many of them were poorly implemented. And there was a really high risk of bias. The results were skewed by a few larger trials that had extremely high rates of C. diff, more so than we see in the general population. So because of the poor quality of the studies, again, it wasn't enough to push for a recommendation. And then there are some meta-analyses that have shown benefit, but the exclusion criteria in a lot of these studies was so significant that they weren't treating any patients that were actually sick or ill, which is the majority of patients that we're testing. So how then are you testing for these patients and who are you testing? You really want to use highly sensitive and specific testing. So this is one of the algorithms that's proposed on the right-hand side. What we do in our hospitals and at UMH, we're checking a GDH, and at the same time, the lab is running a toxin. So we have a sensitive and a specific test that's being run at the same time. If you have conflicting results here, so one positive and one negative, then you can go on to the nucleic acid amplification test, and that can really help you differentiate between what the diagnosis is. Some patients can be colonized, and we need to understand that, but really you need to base it on clinical suspicion. And the other thing that's important here is going to be to determine if these patients are non-severe, severe, or have fulminant disease, because you really need to be aggressive in terms of management, and that's going to come into play in a follow-up slide. So the IDSA and the ACG came out with guidelines this year. IDSA a little bit more recently. So they prefer fidaxomicin over vancomycin, whereas you can see the ACG recommends either. Both of them are very effective. Really what it comes down to is recurrence rates. So if you see here on the left, you have modified intention to treat and then per protocol analyses here, but ultimately very, very good rates of clinical cure here. But what you see the differences are in recurrence rates. So fidaxomicin outperforms vancomycin across the board. And if you look here, you can see that the fidaxomicin recurrence rates are lower and are starting to plateau, whereas the vancomycin recurrence rates are coming, continuing to come down. The other thing, however, that you really need to take into account is cost. Fidaxomicin is very expensive. So if you're not using insurance, if you just want to put pricing across the board, it's $5,000 for a 10-day course of treatment. If you look at the vancomycin tablets, it's about $1,250 for a 10-day course. But if you use the suspension, it's just over $100. So really you need to weigh cost and effectiveness when you're deciding how to treat your patients. Now, what if they have a CDI recurrence? So again, IDSA is really going to prefer fidaxomicin here. Alternatives are oral vancomycin, the same course, or a tapered pulse dose, which I noted down here. Now, these are, again, things where you need to take cost into consideration. But the question is it appropriate to potentially give these patients bezlotuximab as well? So it's a human monoclonal antibody that binds to C. diff toxin B specifically, and it neutralizes the C. diff. It's appropriate in patients who have a high risk of recurrence, and we classify that as a patient that's 65 years or older and has had either their second C. diff infection in 6 months, they're immunocompromised, or they have severe C. diff infection, which goes back to that slide that I was talking about before, a white count of 15 or above, and then a serum creatinine of greater than 1.5. Obviously, taking into account you can't use that in someone with CKD. But these are all important factors to consider when you're treating your patients and choosing your regimen. Again, it needs to be something that they can take. Let's switch over to checkpoint inhibitor colitis. So checkpoint inhibitors have been used with more and more frequency amongst our oncology patients. They're either targeting cytotoxic T lymphocyte antigen or the programmed death or programmed death ligand 1. Initially approved in 2011 with the use of ipilimumab for melanoma, and now has extensive expanded use across multiple malignancies. So we are seeing, however, immune-related adverse events because of how they work. So GI toxicity is one of the most common things that we see. It can be up to 40% of patients. There's severe enterocolitis, which is less common, up to 5% in patients using the PD-1s, or up to 10% in CTLA-4. There's also extraluminal GI issues. Hepatitis can occur and is a little bit more common. Pancreatitis and cholangitis less likely. So this is a picture of a normal colon. I just wanted to show you what things can look like. This is a colon that's somewhat inflamed and irritated. So you see loss of normal vascular pattern, these white spots that are some erosions and ulcerations. And then this is a really severe colitis. I think we can all appreciate spontaneous bleeding and friability. And this is obviously something that we have to be aggressive in regards to treatment. But the question is, why does this happen with these patients? So if you look here on the left, the CTLA-4 binds to this B7 complex, and that inactivates the T cell. If you block it with the antibody, you're allowing for this T cell to be activated and target a tumor cell. Similarly, the tumor cell expresses PD-L1 and the T cell expresses PD-1. So if they bind, again, the T cell is inactive, but if they're blocked in any way, you're getting activation of this T cell. And what you're seeing here is T cell activation. When you have increased T cell activation, you're having pro-inflammatory cytokines that are produced, you're having T cell proliferation, you're having cross-reactivity with autoantigens, and you're also having B cells develop autoantibodies, and you're having autoantibody-mediated damage. So this is how these immune-related adverse events are occurring. Now, how do we manage them? How do we diagnose them? How do we treat them? So we grade checkpoint inhibitor colitis on a score of 1 to 5, depending on how severe things are, and it's based on their symptoms alone. How do we treat it? Also depending on how it's graded. So if they have grade 1 colitis, it's mild. They usually have some diarrhea, no major symptoms. You can probably continue the checkpoint inhibitor in this scenario and use an antidiarrheal. But once patients are starting to have abdominal pain, bloody diarrhea, and things of that nature, you really have to hold the checkpoint inhibitor, check labs, make sure that they don't have an infection in their stool, and then consider a colonoscopy. This is the point where patients are going to start to get prednisone. So the dose is 0.5 mg per kg to 2 mg per kg per day. And some patients will then potentially need IV steroids or even biologic therapy. And how do we decide when we're going to do that? So biologics, the medications that we oftentimes use in inflammatory bowel disease, have been shown to be effective in immune checkpoint inhibitor colitis, and it makes sense based on the mechanism of action. So we're really considering utilizing it when patients haven't had a response to high-dose steroids in 3 to 5 days. We can't predict their need based on the symptoms patients are having. The only predictive factor we really have right now is if we see ulceration on colonoscopy. So it's helpful to have that colonoscopy. And the two main options that we're really utilizing right now are infliximab, which is an anti-TNF alpha inhibitor, and vedolizumab, which is gut-specific, binding to alpha-4 beta-7 receptor in the gut. There's not clear data right now on if one is more beneficial than the other, but there's an ongoing randomized controlled trial at MD Anderson that's assessing this, so it'll be interesting to see. But if you compare infliximab and corticosteroids in this patient population, and this one on the right, to corticosteroids alone, you can see how quickly these patients improve in comparison to corticosteroids alone. And if you look at the data for vedolizumab, they're measuring here CRP, so a non-specific inflammatory marker, and then fecal calprotectin, inflammation in the stool, higher obviously at onset, decreases a little bit with steroids, but a really nice drop here when you're utilizing vedolizumab. So both of these are beneficial to patients. And sometimes you decide on what you're going to use based on the underlying malignancy. A lot of times we do dose these similarly to the way that we dose them for inflammatory bowel disease. When can you stop them? When can you reinitiate the immune checkpoint inhibitor? So patients really have to be doing much better. Their corticosteroid dose has to be minimal to none, and their symptoms have to return to grade 1. So some diarrhea that's not really bothersome. Unfortunately, we don't have effective measures to prevent relapse at this point. So we have to have this discussion with our patients. And obviously some of it depends on the type of treatment that they're going to get. Finally, I just want to put in a quick plug for H. pylori treatment. So we know that eradication rates with triple therapy have decreased remarkably over the past decade or two. We really need to consider patients' prior antibiotic exposure, particularly macrolide exposure. And we also need to make sure that they're getting adequate lengths of treatment, and degree of acid inhibition plays a role too. So clarithromycin triple therapy is really only appropriate when clarithromycin resistance is less than 15%, and they have not had any prior macrolide exposure whatsoever. Bismuth quadruple therapy, a little bit more effective where you have higher resistance rates, where patients have been previously exposed and penicillin allergic. A lot of times though, we're focusing on antibiotic resistance rates, and degree of acid inhibition plays a really important role here too. So there is a medication, an acid suppressive medication called vonoprazan. It is a potassium competitive acid blocker, or a PCAB, not approved in the United States, currently only approved in Asia, but it binds reversibly to the potassium ion and blocks the the hydrogen potassium ATPase enzyme at the proton pump. So it inhibits acid production in that way. And if you look here, you see that in comparison to a BID PPI, there is a little difference. It's still significant, but if you look at daily dosing, there's a huge difference in the degree of acid suppression. And if you look at eradication rates of H. pylori just using amoxicillin and clarithromycin, there are significantly higher rates of H. pylori eradication when you have effective acid suppression. So that's something else that we really need to take into account, and it's extremely important. So just to wrap up here, take home points: start to offer colorectal cancer screening to your patients at age 45. Consider utilization of low-dose aspirin or metformin for chemoprevention of colon cancer in the appropriate population. Consider all factors: cost, effectiveness, and recurrence rates when determining treatment for C. diff. Look for signs and symptoms of enterocolitis with checkpoint inhibitor use, and consider assistance from GI. And then also ensure assessment of local resistance and prior macrolide exposure prior to choosing H. pylori treatment. That's all I have.
Wow, that was a whirlwind of updates in gastroenterology. Really appreciate that. Thanks so much, Siobhan. We have a few minutes for questions. There's a couple of issues. First one is the low dose aspirin. As you know, this lately has received a great deal of press, not only for its use in colorectal cancer prevention, but also heart disease and so forth. Have you had any insight from that, from the data that was used to have this latest publicity that would caution any further about the use of this, or
yeah, I mean,
to tell?
So, I mean, yes and no. I think that obviously the USPSTF is starting to kind of change their recommendations and peel back on the recommendations of utilizing it for cardiovascular risk. I think that you do need to be very specific in the patients in which you're going to consider its use, in terms of their risk factors, in terms of their age, and in terms of potentially their risk of colorectal cancer. So I think it's right now probably an ongoing discussion to have with patients, and data may come out and change, in the near future. And I think the USPSTF is even considering pulling back on that recommendation too. So it's all things that we need to take into account. And unfortunately, sometimes our societies and recommendations go a little bit head to head. So always discussions that we need to have with the patients.
Good, yeah, and not always to rely on the newspapers for our medical input. The other question would be in the realm of immune checkpoint inhibitors. Is there any evidence that the enterocolitis is associated with other checkpoint inhibitor side effects, or things such as adrenalitis or some of the thyroiditis? And do they go together? And do they have any sort of implication for the underlying disease that's being treated in terms of the effectiveness of the drug?
So I think obviously I'm a little bit biased in that I get sent the enterocolitis, and that's what I see. Those are really the most common immune-related adverse events that we see. They do occur in a similar way. The mechanism of action, the pathogenesis is the same. So having one doesn't necessarily mean that you will have an immune adverse reaction in the other organ systems. It's certainly possible. They are obviously related to an extent because of the pathogenesis. However, again, the GI ones are the most common in terms of what we see. If you're treating something of that nature and you have immune-related issues in multiple organ systems, then you probably wouldn't want to use something like vedolizumab that's simply targeting the gut. You would want to use something more systemic. So I think that needs to, be an overarching consideration when you're determining treatment. But one doesn't necessarily beget the other. What was the second question? I'm sorry.
No, that was it. And then the other issue is whether Dr. Lakakis has a question in the chat as to whether or not, if you could use the vedolizumab, would that allow you to begin reinitiation of the checkpoint inhibitors for the underlying malignancy for which it was being used?
So I think in some instances, patients have been successfully, in my experience, able to have reintroduction of the checkpoint inhibitors. The anti-CTLA-4s have the higher rates in terms of colitis and severe enterocolitis here. There's nothing that has shown to be preventative at this point. And we haven't used them both simultaneously. But again, it's definitely something that can be taken into consideration depending on the malignancy, the progression of the malignancy, and goals of care as well. What's interesting is that there's been some reports of this reoccurring a couple of years after patients have had complete discontinuation of immunotherapy. And being off of biologics. And it very similarly mimics inflammatory bowel disease and histology, and you almost can't differentiate them. So the question is, are they having this recurrence of the immune checkpoint inhibitor colitis, or are they having more of an inflammatory bowel disease-like picture? So that's something that's difficult to determine as well.
Thank you very much, Dr. Presto. It was a great grand rounds, and we appreciate that update. Okay, moving on to Dr. Forney to present our next speaker.
Okay. Dr. Christopher Jordan is a staff physician here at University of Miami. He completed his residency in internal medicine at Mount Sinai Beth Israel Hospital and his fellowship in pulmonary disease and critical care medicine at New York Presbyterian Brooklyn Methodist Hospital. Please join me in welcoming Dr. Jordan as he presents his talk titled Advances in Fluid Responsiveness and the Management of Septic Shock.
Hi there, my name's Chris Jordan, so I have no declarations. My learning objectives today are to, one, review the history of techniques used to determine fluid responsiveness in septic shock, and then to describe some of the concepts of non-invasive cardiac output monitoring and passive leg raise and their utility in treating septic shock. And then to appreciate how to utilize and implement a NICOM device to guide goal-directed fluid management in the septic patient. So I'll just start with a case presentation. We have a 68-year-old male who comes in from an assisted living facility with a one-day history of altered mental status, hypotension, and lethargy. He has a limited history that's able to be obtained from him. But what we do know is his past medical history has some CAD, hypertension, hyperlipidemia, diabetes, and HFpEF. He's taking clopidogrel, amlodipine, losartan, metformin, and tamsulosin. And he's a 40-pack year smoker, retired, worked in an office setting. And at baseline, he's relatively independent, but needs some help with cooking and cleaning. So on review of systems, he comes in with fever and chills, a dry cough, decreased appetite, and some dysuria. On physical exam, his temperature is 102.6, his heart rate is 121, he's hypotensive, 86/42, tachypnic, the respiratory rate 33, and his oxygen is 93% on room air. His exam, he's tachypnic with mildly labored breathing. He's in mild respiratory distress, tachycardic, warm, moist extremities, and no peripheral edema. Initially on labs, he has a white count of 21.9 with a bandemia, and he has a bicarb of 13 with an elevated CRP, and a lactate of 6.4. So the patient initially receives 2.6 liters of lactated ringers in the emergency department, broad spectrum antibiotics, and he has improved in his MAP to 72. Heart rate decreases to 106 beats per minute. 1 hour later in the ED, the patient's hypotensive again. So he gets another liter of normal saline. His BP improves to a MAP of 66, and we admit the patient to the IMCU. In the IMCU, this patient is again hypotensive. Now his MAP is 57. He gets a 1 liter normal saline bolus, but now his MAP is only 62. So while we're starting another fluid bolus, the ICU team is called to evaluate this patient. So one of the most challenging clinical assessments in critical care is that of volume status. For a long time, we looked at vital signs, skin turgor, and other physical exam signs to guide our treatment of hemodynamically unstable patients, specifically those in septic shock. And then in 2001, Emmanuel Rivers published a landmark trial that changed the landscape of critical care forever. His concept of early goal-directed therapy brought a new tool to the high mortality illness of septic shock. In his trial, patients got crystallized boluses to target a CVP of 8 to 12, vasopressors for a MAP of 65 or greater, and transfusions of packed RBCs or dobutamine if the perfusion markers were still low. In this trial, the treatment arm received more fluid, 5 versus 3.5 liters over the first 6 hours, and they saw an improvement in mortality from 30.5% to 46.5%. Now, almost 20 years later, there have been several international sepsis trials that have sought to replicate Rivers' data and reevaluate its conclusions in the setting of what we call modern day medicine. In the process, PROMISE and ARISE trials, researchers compared modern day usual care against the early goal-directed therapy protocol used by Rivers. And to their surprise, they found that there was no mortality difference between the two groups. So does this mean that Rivers' landmark trial was wrong? Maybe not. When the researchers looked a little bit closer at the two groups, they found that our usual care now is patients are receiving about 4 to 4.5 liters in the first 6 hours of care. And this is significantly higher than the control group in the Rivers trial that received 3 or less liters. So it seems that Rivers trial was so successful in penetrating the field of critical care that it has essentially become usual care in modern day medicine. The early trials in sepsis made way for the Surviving Sepsis campaign, which has largely been driven by the Society of Critical Care Medicine. And in 2016, they published guidelines for the management of sepsis-induced hypotension and for patients with type A lactic acidosis greater than 4 millimoles per liter. In patients that are without large oxygen requirements, not on dialysis, and do not have CHF, they recommend rapid infusion of 30 ml per kg of crystalloid IV fluids. When patients have increased oxygen requirements, they recommend mechanical ventilation followed by IV fluid boluses of 30 ml per kg. And even when patients are ESRD, on hemodialysis, or have CHF, they still recommend 30 ml per kg crystalloid boluses with frequent reassessment of oxygenation. And this has been shown to improve mortality in these patients. But what happens if our patient is still hypotensive after this initial 30 ml per kg bolus? Do we continue more IV fluids? Do we start vasopressors? Do we go back to checking skin turgor? The question still remains, how do we manage these unstable patients? So to answer this question, researchers really needed to look at some data on how fluid resuscitation affects our patients. So there have been multiple studies that looked at the percentage of patients that are volume responsive after an initial fluid bolus. And it's well documented that only about 50% of hemodynamically unstable patients are volume responsive. And the administration of IV fluids to patients that are not volume responsive leads to over-resuscitation. Over-resuscitation, specifically the one-day fluid administration of over 5 liters of crystalloid fluids has been shown to increase mortality. So it really seems that too much fluid can be just as bad as not enough fluid in these unstable patients. And to really understand why only 50% of patients are volume responsive, we have to go back and look at the Frank-Starling curve. So when we administer a fluid bolus, our goal is to increase the ventricular end diastolic volume or preload. And we're hoping that an increase in preload will result in an increase in stroke volume and subsequently cardiac output. This is shown in the purple line here for patients with normal ventricular function. So the problem comes when patients are over-resuscitated, they kind of move towards the right of the Frank-Starling curve so that the same fluid bolus now results in a much smaller increase in stroke volume, and it eliminates the desired effect of our treatment. And in patients with decreased ventricular function, shown in the orange line, this effect is accentuated so that even at relatively low preload levels, the patient is still not able to mount an appropriate stroke volume response to a fluid bolus. This all taken together really seems to point to an optimal fluid volume load for each patient. Too little fluid and the patient is going to experience hypoperfusion of their organs and increased mortality. Too much fluid and they're going to suffer from edema, increased oxygen requirement, and again, increased mortality. So how do we find the optimal fluid load in each of our patients? This seems to be the million-dollar question. And this is why volume status and fluid responsiveness are some of the among the most challenging assessments that we perform in the ICU. So for over 30 years, we've known that traditional methods such as monitoring vital signs, physical examination, these are just not reliable to measure changes in cardiac output. So we started looking at other measures that might help. Over time, there have been both static and dynamic measures that we tried to use to assess cardiac output. Some of the static measurements have been CVP taken from a central line, and later dynamic measurements involved, such as cardiac output taken from a PA catheter. But the PA catheter was invasive, and so we started looking for more non-invasive techniques. And we studied things such as stroke volume variation, pulse pressure variation, and NICOM, which is non-invasive cardiac output monitoring. So let's take a look at each of these just a little bit closer. Central venous pressure has been studied extensively for the past 35 years. And although it's often been used as a surrogate for volume responsiveness, studies as early as 1984 clearly showed that it is unreliable. Shippey back in 1984 collected over 1,500 CVP studies and blood volume measurement studies, blood volume measurements, and showed that CBP measurements did not correlate with either a deficit or an excess of blood volume in patients. And these results were replicated by the Osman group in 2007. And he looked at CBP as compared to pulmonary artery wedge pressure and found a really poor correlation between the two measurements. So it seems like CBP is not the answer to the question of volume responsiveness in patients. So then we started to look at the PA catheter to guide fluid management. And for a while, it seemed like everybody in the ICU had a Swan-Ganz catheter. But in 2005, there were two large studies that examined whether a PA catheter was helping or maybe doing more harm. In the ESCAPE trial published in JAMA, a group found that PA catheter had no effect on mortality, had no effect on length of stay, and had increased adverse effects. And then this was replicated with the Pacman trial published in the Lancet in the same year that showed no benefit in managing critically ill patients, and PA catheters came with a 1% complication risk. And kind of with these studies, the PA catheter made its exit from the ICU, and it's pretty much a rarity to find one in a septic patient in an ICU these days. So then we moved on to look at stroke volume variation and its surrogate, pulse pressure variation. So stroke volume variation is the change in the amount of blood ejected from the left ventricle into the aorta with each heartbeat. And this is reflected by arterial blood pressure changes in relation to the pattern of respiration. If you have a spontaneously breathing patient, the blood pressure slightly decreases upon inspiration. We call this pulsus paradoxus. However, if we have a mechanically ventilated patient with positive pressure breaths, the arterial blood pressure may be expected to rise during the inspiration and fall during expiration, initially called reverse pulsus paradoxus. So there have been numerous studies that have showed that a pulse pressure variation of greater than 12% predicts fluid responsiveness reliably. And so we thought, finally, we can use pulse pressure variation and we have something to guide our fluid management in our patients. Unfortunately, this just might not be true for all patients in the ICU. Pulse pressure variation measurements come with a list of caveats. Most importantly, it's still invasive. It requires an arterial line, which makes the patient have to be in the ICU. And it requires that the patient is in sinus rhythm, which is concerning because atrial fibrillation is one of the most common arrhythmias that we see in septic patients. And the patient has to be fully mechanically ventilated with a tidal volume of 8 ml per kg ideal body weight or more. And with the advent of low tidal volume ventilation, we just don't ventilate our patients at these high tidal volumes anymore consistently. And so again, we had to look for other measurements to guide volume in our patient and enter the NICOM monitor. So the NICOM monitor is a non-invasive monitor. It measures cardiac output, and it's based on a technology called bioreactance. The NICOM monitor works by first applying a series of pads to the patient's clavicles and the abdomen on both the right and the left side. The machine delivers a 75 kilohertz current through the outermost pads, and then it records the signal through the inner pads. The blood flowing through the thorax causes an electrical field that delays the signal returning to the inner pads. And it's this signal delay that is proportional to the volume of blood in the thorax. So NICOM is a measure of volume. And we know if we measure volume over time, then we can calculate flow. So if we take the derivative measurement of the NICOM signal, we essentially take the area under the curve. And if we take this during systole, this represents the total systolic flow, which is equal to the stroke volume. So the monitor averages this signal over an entire minute, And it essentially filters out artifacts and delivers reliable data that's independent of the mode of ventilation, the presence of ventilation, and the presence of arrhythmias such as atrial fibrillation or patient movement. And this makes it applicable to a much wider range of patients. But then the question still arises, how do we use NICOM to determine if a patient will respond to fluids? So numerous studies have shown that a change in cardiac output by 10% after a fluid bolus corresponds to a patient adequately responding to that fluid bolus. And because cardiac output is heart rate times stroke volume, if the stroke volume increases by 10% with constant heart rate, then cardiac output should increase by 10% as well. And this is kind of how we've come to label a change in stroke volume by 10% as a measure to correspond with a patient being fluid responsive. To just see this visually, we can go back to the Frank-Starling curve. And in our patients with normal ventricular function and low preload, we'd expect a fluid bolus to result in a change in stroke volume greater than 10%. Here it's 15. But when the preload is already very high, which would be the case if your patient was overly over-resuscitated, then we would expect the change in stroke volume would be less than 10% for a given fluid bolus. And if you already have decreased ventricular function, the change in stroke volume may never meet the 10% cutoff, no matter what your preload is. But to utilize this, we would have to give our patients a fluid bolus to figure out if they were volume responsive. And this is problematic because we would always end up giving our patients one too many fluid boluses. And to address this, the researchers came up with what's called the passive leg raise. So to do a passive leg raise maneuver, the patient's first placed in the semi-recumbent position at a 45-degree angle for 3 minutes to obtain a baseline. And then they're quickly laid down and the feet are elevated by 45 degrees. And this causes the blood from the lower extremities to flow into the thoracic cavity and increase preload. The passive leg raise delivers approximately 300 milliliters of blood. And importantly, it's a reversible fluid bolus. If the passive leg raise results in an increase in cardiac output by 10%, then it was shown that it can be an excellent predictor of fluid responsiveness in patients. The passive leg raise has a positive likelihood ratio of 11 and a negative likelihood ratio of 0.13 for fluid responsiveness based on a study out of JAMA in 2016. There are several clinical situations where a passive leg raise might be contraindicated based on the patient's diagnosis. And this is going to include patients in cervical spine collars, any patient with increased intra-abdominal pressure, or patients with increased intracranial pressure. In these patients, we can go back and substitute a 500 ml fluid bolus, and that can be a substitution for the passive leg raise. So in 2009, the Marquis group studied postoperative cardiac patients and compared cardiac output measurements from NICOM to those of a PA catheter using thermal dilution. They studied over 12,000 paired measurements, and they were looking at both pulse pressure and NICOM measurements, and they found that both showed a strong correlation to PA catheter measurements. Additionally, both pulse pressure variation and NICOM measurements were obtained faster than PA catheter measurements. They took less than 7 minutes compared to much greater than 7 minutes with a PA catheter. Additionally, the sensitivity and specificity to detect changes in cardiac output were measured, and NICOM was found to have a sensitivity of 91% and a specificity of 95%, while pulse pressure variation was found to have a sensitivity of only 86% and a specificity of 92%. And based on this data, it seems that NICOM might outperform pulse pressure variation when measuring cardiac output. But the question still remains, will NICOM and its use to guide fluid measurement translate into improved patient outcomes, which is what we're really interested in. We know that cumulative fluid balance predicts non-survivors in the ICU. And unfortunately, several studies have shown that 2/3 of septic shock patients demonstrated fluid overload on day 1 of admission. And this positive fluid balance was often carried through ICU discharge, which confers increased risk to our patient. And so to assess the impact of NICOM measurements on patient outcomes, the Douglas Group in 2020 completed a prospective randomized control trial in 13 hospitals in the United States and the UK. This trial was called the FRESH trial, which stands for Fluid Responsive Evaluation in Sepsis and Hypotension and Shock. And they looked at 150 patients presenting to the emergency department with hypotension. And this was a randomized intention to treat trial. Patients in the trial all received initial resuscitation with 30 mL per kg of ideal body weight fluids. And this ended up being somewhere in between 1 and 3 liters of fluid. And then they were randomized in a 2-to-1 ratio into usual care or into an interventional arm. The intervention arm received clinically driven fluid boluses or an increase in vasopressors based on NICOM measurements utilizing a change in stroke volume index. And the cutoff for fluid responsiveness was a change in stroke volume greater than 10%. So this flow diagram summarizes their clinical decision tree. After the initial fluid resuscitation, if the patient had low urine output, a MAP less than 65, a systolic blood pressure less than 90, or a blood pressure was trending down, they were connected to a NICOM machine and a passive leg raise was performed. If the change in the stroke volume index was less than 10%, the vasopressors were added and they were titrated to a MAP of 65. But then if the vasopressor dose doubled, an additional passive leg raise maneuver was performed to check for further fluid responsiveness. If the change in stroke volume index was greater than 10%, then patients received a 500 ml bolus and the MAP was again measured. If they were persistently hypotensive, they received another fluid bolus. And if they were persistently hypotensive after that, they would go back and perform a second passive leg raise. And they kept doing this until the patient had a stroke volume index change that was less than 10%. Primary endpoints were collected at 72 hours and at ICU discharge, whichever occurred first. And the results were quite striking. So as compared to usual care, the intervention group had a significantly lower fluid balance. They had less need for renal replacement therapy, and they had less need for mechanical ventilation. And all 3 of these were statistically significant. Additionally, patients in the interventional arm were more likely to be discharged home alive. Although this study was not powered to detect a mortality benefit, it did have a non-significant trend towards improved mortality in the intervention group. These results show that the benefit of using NICOM to guide critically ill patients with sepsis is definitely or maybe there. So if we take this and kind of return to our case and see what happened to our patient, the ICU team came to evaluate our initial patient, and they performed a passive leg maneuver with the NICOM monitor. In this case, the change in SVI was 4, which is less than 10, and so they were started on vasopressors. The patient remained tachypnic with labored breathing. They were placed on BiPAP. Eventually, they received 40 milligrams of furosemide, had 1 liter of urine output over the next 2 hours, and were liberated from the BiPAP. Subsequently, urine cultures and blood cultures came back positive for E. coli, which was pan-sensitive. And ultimately, the patient ended up spending 2 days on norepinephrine. And after the norepinephrine was titrated off, they got some additional doses of Lasix and were transferred from the ICU and after 4 days. So just a couple of take-home points. I think that NICOM as a diagnostic tool can be used to assess fluid responsiveness in patients with septic shock using a change in stroke volume index with a cutoff of 10%. And NICOM in combination with a passive leg raise can help to guide fluid administration, especially in patients in septic shock, and may improve outcomes. And I think a really important thing is, unlike a lot of the other measurements that we have been looking at previously, NICOM is not something that necessarily needs to be implemented in the ICU, unlike pulse pressure variation or PA catheters that require an arterial line. NICOM is something that could be used in an IMCU or on a general medical floor to answer these difficult questions that we have for our septic patients. And that's all I have.
Thank you, Dr. Jordan. That was really a very cool grand rounds with lots of new information. You know, last month in JAMA, there were a series of articles that talked around this issue of fluid resuscitation. And I saw at the beginning of your case presentation, first they gave lactated ringers, then they gave saline. And do you have an opinion based on the latest data that came out last month as to whether or not saline is better than a balanced salt solution? And in that series that they looked at, they used both rate of infusion and type of infusion. Can you make a lay person, that is a lay critical care person, understand that?
Yeah, so I think that, you know, there were 2 large trials that looked at patients in the ICU and patients outside of the ICU that looked at either normal saline versus balanced fluids. And I think that there is probably a small benefit to using balanced fluids such as lactated ringers over normal saline. And I think that this will need to be repeated. To answer your question about the rate of infusion, I believe that those trials did not show a real big difference in how quickly you're giving the fluid. And so patients who you might be more concerned about congestive heart failure, I think you could give the fluid a little bit slower. I think that the idea is that we try to at least have some standard for initial resuscitation, and then after that, try to move to some measure of looking at their fluid responsiveness to guide further therapy. I think it's very clear that we should not be using non-crystalloid, like colloid type of infusions, such as albumin in these patients, because there has not been shown to be a difference between using crystalloids and colloids, and they probably are more expensive. So I think that answers.
Thank you. That answers the question. Thank you, Dr. Jordan. Thank you, Dr. Proksell. Both of you did a great job today. Please pay attention to the link in the chat in order to receive MO.
Yes.